the one thing that our bodies change for both women and men is that the only thing that changes as we age is the fact that our hormones become deficient. And so because of that reason, our quality of life, our overall health is being affected negatively by the fact that our hormones are being lost. And so, for both the fact that your overall health is improved when you are on HRT the right way, and your quality of life improves, that I believe that all women and men should be on it.
Welcome to Bathroom Diaries, where we explore science, psychology, and culture of aging. Today's conversation sits at the crossroads of fear and innovation. Hormone replacement therapy was once standard care. Then, the Women's Health Initiative study in 2002 changed everything. An entire generation of women stepped back from hormones, and many suffered in silence. Now, 2 decades later, we're re examining the data. At the same time, peptides have entered the conversation, a small signaling molecule with potentially big biological implications for metabolism, recovery, cognition, and body composition. But in a world where trends move faster than evidence, we have to ask better questions. What do hormones actually do in the aging body? What do peptides really modulate, and what is hype? Where does innovation meet responsibility? To explore this intelligently, I'm joined by Dr. Rob Frankel, emergency physician, longevity enthusiast, and host of Modern Man podcast. He's my colleague and mentor for over a decade, and our podcast, which we conducted last month, was very well received, which is encouraging us to come together and talk more about other things that are simultaneously taking place. Let's examine what we know, what we don't know, and how to navigate both without losing our scientific footing. Hello, Dr. Frankel. Thank you once again. And I hope that you can be a regular feature on my podcast.
Well, thank you, Dr. Din. It's a pleasure as always seeing you, and I get to see you twice in only a few weeks. It's very exciting for me. So thanks for having me back. And yeah, I think this is a really valuable and important topic. I'm very excited to talk about it. I've been doing HRT for over a decade with my patients, and I think that it's something that traditional medicine has really kind of dropped the ball and has really hurt a lot of women and men in this field. And I'm excited to discuss it with you and the new landscape of what we're seeing right now.
I know after the WHI study, we essentially abandoned millions of women. What did the data actually show versus how it was interpreted?
Well, I think that what they kind of were looking at is they were looking at a small focus, of patients. Um, and the one thing about HRT is that you have to understand that there is different types of HRT. There is the synthetic hormones, which a lot of traditional medicine uses, such as the oral contraceptive, and a lot of the synthetic progesterones. And they work differently than what we work as, um, longevity doctors, anti-aging doctors. We use bioidentical hormones. And the difference is the way that the hormones actually react to the receptors in our body. with a lot of the synthetic hormones, one of the biggest problems with them is that they actually don't do well on the receptors. And often they block our women's natural hormones because of the fact that they are not kind of made for that type of reception. And so the bioidentical hormones, because they were created in a way where they work with our natural receptors, they actually work to enhance the hormones. And that's really kind of the major game-changing difference in the way that we've used hormones.
Yeah, so initiating one of my like very important questions for right now is that those women who have missed 10 years or so of HRT, um, do you recommend them getting reintroduced into HRT also? And is there like a particular protocol that like I know the bioidentical, that's also a very important question, but like, do you recommend, and is there like a particular protocol that you follow?
So my feeling on HRT is a very strong feeling on it. I feel that the one thing that our bodies change for both women and men is that the only thing that changes as we age is the fact that our hormones become deficient. And so because of that reason, our quality of life, our overall health is being affected negatively by the fact that our hormones are being lost. And so, for both the fact that your overall health is improved when you are on HRT the right way, and your quality of life improves, that I believe that all women and men should be on it. But of course it has to be done correctly with a physician who really understands what has to be done and how to do it. One of the biggest problems with the original study was the fact that when they were giving patients these synthetic hormones, they couldn't test their hormone levels because their bodies weren't recognizing them as true hormones. And so they weren't able to see like how much of estrogen, how much progesterone, how much testosterone was in the body because of the fact that they were giving them something synthetic which couldn't be tested in the blood work. And so they didn't know if people were estrogen, they had too much estrogen in their system. They didn't know whether they didn't have enough progesterone in the system. And so the fact is that as long as it's done in a way where you're giving the hormones, you are consistently checking every 3 to 4 months the levels of the blood work, that is going to be the best way and the only way to do it in a smart way, efficiently, and safely for our patients.
Wow, that's important because many times I see that it's really not, nobody's like really checking the hormones, and I think insurance won't even cover checking it so many times. Um, so how do you treat their perimenopausal or menopausal symptoms by do you follow their levels of hormones in the body, or is it more of treating their symptoms? Like once, like it doesn't matter what level it is, we're not chasing a number, and it's just like a symptom. Where at what point your symptom is relieved, and does that become the minimum effective dose?
No, I think that the most important thing is to check the hormone levels. Now, for most women at a certain age, you can kind of predict what you're going to be seeing when you check their hormones. Occasionally, you'll be surprised by what the levels of the blood work show, but more importantly, you can track what exactly the hormone levels are doing, meaning that one of the most important things is that for women, when they don't have progesterone, this progesterone has a lot to do with sleep, mood stability, and just overall, their overall sense of well-being. And so what that means is that, a lot of times what I'll talk to women about before they start hormone replacement, the first thing I'll ask them and I'll say like, your overall, psychological health, is it, do you feel up, down, or do you feel just generalized gray? I often say that I don't think that it's a depression, but it also, for most women without progesterone, a good amount of progesterone, they're going to have kind of that gray feeling, that kind of overall kind of like blah feeling, which is, like really hurts their quality of life, as well as they cannot get into deep sleep. And one of the biggest thing is traditional medicine. If you talk to an OBGYN, they'll say, well, you're postmenopausal. Why do you need progesterone? It's the exact opposite of what women need. It infuriates me when I hear this, and I hear this all the time when they say their OBGYN, says that this is something that they don't need. It is absolutely insane to me that that's the case. But it's important to look at the levels. I do think that the levels are important to kind of follow, because our bodies metabolize hormones differently,
Mhm.
depending upon your weight, depending upon how your body's accepts them. So I think that it's important. And most of the times the symptoms that they have will track exactly with what you're seeing on the blood work.
I see. So you will definitely, for somebody who's postmenopausal, for like a bunch of years, for you to start reintroducing hormones into them, you will first check their levels, which will probably be nil because they've been postmenopausal for like years. So at what, and then you will start reintroducing. Is it like do you reintroduce all the hormones at the same time, or is it do you layer them? And
Most
then
of the time, go
what
ahead.
would
I'm
you
sorry.
tell them to check?
Yeah, so I mean, for the most part, you're right, Dr. Din, that for the most part, the hormones are going to be lower than normal, obviously, because they're not producing. But you have to understand, for women, I mean, men is a completely different animal. Men are simple, as we men are.
Not
Um,
really, but still, you
but
insist.
but women are more, they're more unique, they're more complex, they're just, they are, more interesting than men, because of the fact that their bodies are going to have a different kind of flow of their hormones. So what we find is that, yes, estrogen, progesterone, testosterone, the three sex hormones that we look at, are all going to be low. However, estrogen is produced not only by the ovaries, but they're also produced in fat cells and as well as the adrenal gland. So for the most part, even though that women have lower levels of all the hormones, estrogen will be the dominant hormone. And so this is the reason why women have an increased risk of breast cancer, ovarian cancer, postmenopausal, because they are estrogen dominant, even though they have very low estrogen compared to when they were in their 30s, 40s, even 20s. They have more estrogen than anything else in their body. And so what that means is that estrogen is a cell proliferator, means that it produces a lot of cells. Progesterone is what we call a cell differentiator, which means that it takes those cells and makes them into normal cells. If you don't have that balance, what ends up happening is that it increases the risk of those cells that are being constantly produced to be create into abnormal cells like cancer cells. And this is the reason why that women are often, even though they have low hormones, they are estrogen dominant. So you have to fix that balance, and you're really trying to fix the balance more than anything else. And that's the first step that you need to do.
Wow. So at what? So would you also recommend starting testosterone at some point at a because I am under the impression that until now we do not have testosterone dosages available for women.
Absolutely. I mean, every one of my patients, my female patients, usually will be started on estrogen. They will be started on progesterone and testosterone. Testosterone for women is incredibly important, not only for libido, things like that, but it's also important for their bone, their muscle, as well as their sense of well-being. similar to men. There is like a psychological sense of well-being that testosterone gives both men and women. Now the dosing is different, obviously. Obviously, for women, it's a much lower dose. But the reality is that women do need testosterone as well, and it has to be all balanced together with the estrogen, the testosterone, and the progesterone together. So, yeah, absolutely. Because again, bone strength is one of the most important problems that we see in women. And, with estrogen is one of the keys to preventing osteoporosis. But the other thing is testosterone as well. I have to say that one of the things that you hear a lot, and this kind of drives me crazy, because again, like I said, I work in the emergency room. So we risk stratify patients, right? On, let's say they have worry about cardiac disease, high cholesterol. We say that women who are postmenopausal are at a higher risk of cardiac disease, which is true. But what is the reason for that? No one ever discusses what that is. And the reason is actually that estrogen is a key for keeping the vessels more flexible, decreasing blood pressure, decreasing cholesterol, and overall cardiac health is in, vital that you need estrogen because it actually helps collagen kind of build within the muscle, as well. So all these things together is the reason why women who are postmenopausal have a higher risk of all these things, as well as breast cancer and endometrial cancer and all the sex hormone cancers as well.
That was one of my questions also, because one of the things that really scared away so many women from this
Mhm.
is the fact that the risk, do hormones cause cancer? And can hormones cause cancer when you're using them? So it's like using something that is like so potentially hazardous if it is like not monitored. Is that the case postmenopausally?
Absolutely. I mean, and a lot of times the way that, women are receiving these hormones are the exact wrong way that they will get them. I'll see patients that come in that they'll have, like they'll get vaginal cream estrogen without any progesterone, anything to back them up. So without even checking their levels, they're becoming even more estrogen dominant than they were to begin with. And of course, estrogen is going to be one of the main drivers of breast cancer and endometrial cancer. And if you're not using your hormones to balance it out normally, then that's going to hurt it. But to begin with, before you even do anything with HRT, women already have an increased risk of those breast cancer, endometrial cancer, because of the fact that they are going to almost always be estrogen dominant just because they're postmenopausal, because they're not producing progesterone anymore. And so without progesterone, you don't have that balance that's actually helping women protect them from these cancers. And that is the reason why it's vital that progesterone needs to be introduced for almost every postmenopausal female. I mean, to me, it is like it's almost malpractice the way that, when OBGYNs who should understand this, they really should say that what do you need progesterone for? Because of the fact that you don't, whether you're had a hysterectomy, whether you're postmenopausal, it doesn't matter because of the fact that that balance of progesterone, besides for quality of life, is so important for your overall health and prevention of cancer. But it has to be done right. Yes, you have to keep checking the levels to make sure what you're doing is the right thing for the patient.
And so for progesterone, would you recommend a pill or would you recommend a patch? Because I do see like people doing combi patch kind of thing. Or is it like a pill is better because you can monitor it or something better?
So, like particularly
And
for
what about
bio,
pellets? Sorry, I want to also, but if you can, yeah, because testosterone, a lot of women are taking pellets, and I know that you were the first person who was like, no, you need cream as testosterone. So, can you please expand on that because that's very important, I think.
absolutely, yeah. So, yeah, I'll tackle all of them, together. So, yes, for the most part, the progesterone pills are best absorbed by the body. So the one thing about hormones is they have a different, different ability to be absorbed, as well as, some certain hormones are better absorbed than others. Like, for instance, estrogen really should never be given orally. It's not a good pathway for estrogen to be given. It doesn't absorb well. It creates risk. It actually increases the risk of things like blood clots if you take it orally compared to if you're taking it, transdermally by cream, or you could even do patches with it. But progesterone particularly are fine to give orally. People, it's easy, and it's actually best absorbed done orally. So yes, I would say that orally would be the best way to do it. You can do progesterone as far as delivery with cream and even transdermal, but orally, seems to be the best way that our bodies kind of take it in. um, Now, as far as the pellets go, yeah, I have a lot of strong opinions on pellets too, because I have a lot of patients, both for females and males. The reason why I don't approve or don't like pellets is because of the fact that when you work with hormones, you have to realize it is not the type of medication that you give that is a set it and forget it. Meaning, like, okay, like your blood pressure medicine, you can give the same dose pretty much for the entire time that you're taking, that you give this to the patient. Maybe once in a while you change it, but for the most part, if you're giving a blood pressure medicine, you're going to give the same dose. It's going to be the same regardless. Hormones are very different. And the reason why they're different is because our body composition has to take it in, and it actually has to kind of absorb it in a certain way. So, for that being the case, that if you put a pellet into the body, once you put it in, you cannot fix the hormones. Meaning that, let's say the levels of estrogen goes up, let's say the levels of progesterone, let's say the testosterone levels go up. You can't, or down. You can't fix that now because of the fact that for whatever reason, your body's taking it in differently than it was when you first took the hormones. Now you cannot fix it because you've already just put these pellets in that are going to either, you know, surge a lot of hormone all at once, and then eventually none will come out. There's really no way to regulate the hormone, which I think is actually more dangerous. That's the most dangerous way to give hormones, because of the fact that there could be surge of hormones that you can't stop. Whereas if you see your levels are going up for a reason, you lower the dose with the creams, the pills, for men injections. You have ways to be able to regulate the hormone, which you don't with the pellets. So I'm a big fan of not doing pellets. I don't approve of them. I don't like them. The doctors who do them, I mean, full disclosure, make more money doing them, and I think that that's part of the reason, or maybe don't understand it. And it's more convenient. I get it. I understand for patients, they're like, they get this placed in, but with hormones, it's really kind of it's more of a participation sport. The patient has to be part of the treatment as well as the doctor, because the way that they are receiving the hormones, the way that the symptoms are taking it in, are vital to the fact that how you're going to deliver the hormones.
What about is a vaginal estrogen, estradiol, as a pill or as a cream? Um, do you use it, and do you recommend mixing it with testosterone cream? One of the
Yeah, I
questions.
mean, for some patients, again, every individual is different. If some patients who have like severe, dryness, atrophy, even urinary symptoms, I would use it as a part of a delivery method. I
Mhm.
like I worry about like using it as the only delivery method for estrogen, and the reason is because in the vaginal tissue, there's a lot of blood vessels, right? So it sucks up the hormone very quickly, and so it uses it, and then it kind of like weeds through our bloodstream. The way that you really want to kind of use hormone therapy is the fact that you want to let it kind of sit in your fat and let the body kind of take it in slowly. And that's the best way that you really get hormone therapy, because you want it to allow it to kind of mimic as best as you can the way that your body used to do it, meaning that it takes the hormone in slowly, it doesn't surge it, it kind of takes it in when it needs it. And so that's the reason why I advocate for doing, the creams, because the creams allow the hormones to sit in your fat and then slowly enter into your vessels, into your body as it's needed. And so that's the reason why I think that, vaginal creams for certain patients are helpful for if they're very symptomatic in that, that area. But I think that, if you're going to do it for full treatment, you want to do it more systemically, like in the fat. Like I'll tell patients in the legs, the arms, as a better alternative for the delivery method.
Or a patch? Would you recommend a patch
Yeah,
for
I mean, I
like
think I think again, one downside with the patch is usually they're dose dependent. Their dosing is difficult, but you can, like I think patches are fine if you don't want to, like do the cream every day. And some people just have a hard time. They have reasons why they don't want to do it. So I think patches are fine. You could even do sublingual troches for some patients. They do fine for some patients. Everybody's different, and that's why we look at their results. They look at their symptoms. Are they getting it actually delivered to their system or not? And that's one of the ways that we know, by constantly checking the blood work, checking in on them, seeing what their symptoms are. Are they responding to the treatment, or do we need to do something better?
W- That's great. When you are checking blood, um, is there a particular time of especially for a postmenopausal woman? I mean, is that how can they just go anytime and check it because it's no longer a cycle?
Right. So yeah, for women who are postmenopausal, then yes, you don't. There doesn't have to be a specific time that you check it. For women who are on their cycle, you want to do it best on days, basically 18 to 24 is kind of the range. From 18 is the 18th day after your first day of your cycle to 24 days. And this is kind of like where you see where the hormones are at their highest surge, right before they're going to have right before they're going to have their menses. So that's where you really want to kind of look at their hormones. For women who are postmenopausal, yeah, doesn't have to be as timely. I mean, uh, I usually say like 3 to 4 months. So we kind of range it in that rare. Wherever we started, we'll go, 3 to 4 months post, depending upon that particular patient. So it's for postmenopausal, yeah, it's easier. For patients who are still having their cycle, then 18 to 24, 18 to 22, that's kind of the range you want to stay at. So
Another question that I have is um, what is the difference between um, contraceptive patches and hormone replacement therapy? Because I have also seen that a lot of women in their 40s, they're getting into perimenopause and menopausal symptoms, and they are on some form of birth control. Do they now need to change the way they're introducing hormones into themselves?
yeah, absolutely. Because when you're using like any of the oral contraceptives, they are synthetic hormones. And with that, they create the risk of their body not responding to the hormones the same way. And again, the important thing about the synthetic hormones is that, especially as you go, further into menopause or even perimenopause, you need to be able to test like where the hormone levels are. with synthetic hormones, you really can't. Your body just doesn't recognize it the same way as it does with the bioidentical hormones. So you can't really use it as a gauge by doing the blood work. And that's why in most cases, like when patients are put on these, then they'll never get hormone, like blood work for these patients because it's not going to show anything. So yes, I'm a big advocate against
Yeah.
synthetic hormones for lots of reasons, and mostly because of the fact that instead of actually increasing, the effectiveness of your hormones, a lot of times it blocks the natural receptors. So
Wow. Yeah, no, so one of the another question is like for a treatment like this, for instance, if your insurance is not covering unless it is like a synthetic hormone and you have to go and purchase it out of pocket, what would be the appropriate like approximate cost per month for women to consider? Because now this is entering as an additional cost on top of their other anti-aging costs.
yeah, again, what does it cost for your overall
Oh
health?
yeah, it's priceless. Priceless.
Exactly.
Yes. Yes.
But yeah, I mean, there are some insurance companies that will cover the hormone therapy if they don't. And I think that the interesting thing is that with kind of um, the new kind of FDA kind of appearance that they're taking the black box warning off hormones and all that. I think that there might be a lot more insurance companies that are going to be more receptive to um, the
Covered.
coverage of the hormones. So I think that's one thing to consider. It all depends on what the treatment you're getting. I'd say probably in the range of 150, 100 to 150 per month, maybe a little less, maybe a little more, depending upon each patient. But I think that that's kind of the range. It's how many Starbucks can you get for that?
Oh, totally legit. Totally legit. This is like, yeah. This is
Yeah,
like,
maybe like
um,
20 Starbucks for that price. So
yeah, no, I'll skip the Starbucks.
that's it.
That's
That's it.
it. So, I didn't go onto the testosterone section for the men side because I think that we'll do that, the male hormonal replacement for
Sure.
andropause on just a separate section. And I think I
Sure.
have like so many questions that I don't even want to get into that part yet.
Sure.
I do. I'm going to save it for your part three of your peptide playbook because I'm sure that based on this, we'll get like a lot more questions to ask
Sure.
you.
Sure. Yeah.
Um, but let's move on to your top favorite peptides. And I think we have a slide for it, which I'll ask her to pull up. And then I would like you to help us understand um, peptides.
I mean, again, there's really no replacement for replacing hormones when women are in need for sure. So that's the first thing. It's kind of the foundation of the building that if there are deficiencies in hormones, they need to be addressed for these each individual patient because I think that that's really kind of the key. But there are a lot of symptoms that women will get, with hormones being deficient, that I think that it's valuable to look at because as you kind of get balance with your hormones, it does take time for women to kind of reach all the benefits that hormone replacement gives you. So I think that there are certain things that we can help them to adjunct with peptides to really improve their quality of life and improve their overall health. So the first one that I picked out is the GLPs. Now, the GLPs, obviously, you and I have talked about, extensively in the past. Those are the GLP-1, which is semaglutide, GLP-2, which is trizepatide, and GLP-3, which is retatrutide, which is the newer peptide. So, I mean, I think that for, for this, I mean, it is vital to realize that, the body composition of women when they become perimenopausal and postmenopausal becomes different. And, I think that most people, recognize that decreased lean muscle, increased inflammation, and just in general, overall kind of increase in insulin insensitivity, cognition. And so one of the things that GLPs do are help all of this, meaning that they will decrease, the amount of, adipose, fat cells, in the body. You're increasing lean muscle. Bigger thing, really, which really is interesting, is inflammation, overall inflammation in the body. I mean, it's just incredible to me that I have patients who have reached their goal weight, but they still coming back to doing the GLPs because of the fact they tell me that they have, like arthritis, RA, it's all different types of inflammatory conditions. And as soon as they get off the GLPs, all the joint pains and aches start coming back, and they feel like they need, that, maintenance of GLPs to keep them from that inflammation, the bloating, the inflammation, the joint pains. They're all there, that are improved by the GLPs. Again, I can't speak, like good enough about the GLPs, because I think that they're something that is, historic in our lifetime, to see these type of medications, that have changed people's lives in such a dramatic way. I don't think there's anything that we've ever seen in our lifetime that has done that, what they've done.
Yeah, no, they're miracles. Yeah, I modern medical miracles, I would call. And even though insurance is covering it for diabetes and sugar neutralizing, but I believe that there should be an indication for helping people with menopausal and andropausal symptoms, such as metabolic sluggishness. Just the metabolic sluggishness is so difficult to overcome. Even the best people with the best capacity to work themselves out can just not outrun the metabolic sluggishness that accompanies the pause. So
Right.
100% I agree with your number one. I
Because progesterone really does help, do that for us. But what DSIP does is, it, as a GABA analog, it actually helps our body go into, and they did a lot of studies where it showed that it actually helps kind of fix patients' circadian rhythms. And so they go into deeper sleep. They actually get more restful sleep and regeneration at night. And what's different about DSIP versus, say, like benzodiazepines, which is a lot of times people will take Xanax or Ambien to go to sleep at night. These drugs, A, don't put us into non-REM sleep, meaning they don't put us into deep sleep. So we constantly feel the next morning as we're hungover, even though that we were maybe unconscious, we weren't going into that deep, restful, regenerative sleep. So those patients wake up essentially with a hangover, still tired, still kind of fatigued, agitated a lot of times. But the bigger thing is that with DSIP, it's not a peptide that's going to be addictive like these benzodiazepines, which are. And so it's not that your body gets used to having to take these every evening, but what it does do, it definitely helps increase your deep delta sleep, which you can't get, in a lot of ways. And a lot of the drugs that are on the market will put you to sleep, but they won't put you into deep sleep. And for a lot of women, their biggest complaint to me is that they wake up, night after night, they're up 2, 3, 4 in the morning because they can't get into deep sleep. And that's one of the things that really, overall hurts our overall health, because we really, really need sleep to regenerate ourselves. So this is actually a great peptide. Not super well known, but it really is a super valuable peptide, especially for, these type of patients.
Is this an injectable?
This is injectable, yes. I
And
think they
how
do
often
have.
how often do you inject yourself with this?
So like this is one of the injections that you could do, 3 times a week. Sometimes it's like you can correct your circadian rhythm and you might not be out have to do it, for a period of time. It's just as more of a maintenance. So it really kind of depends on how your body is taking it in. But usually we say like, especially at the beginning, you can do it 3 times a week. Um, before sleep, and you find these patients go into like the deep delta sleep, and they
Wow.
kind of like their circadian rhythm starts to kind of adjust to this, and it's a really incredible peptide.
What pathway is it
So it's a
targeting?
GABA analog. So it
Mm.
helps with GABA. It's actually improving kind of the way that the circadian rhythm kind of is present, and so it really makes a huge difference in deep sleep. So it's a
So,
cool
is
peptide.
there any the side effects to it, or are there people who you will not give it to?
For the most part, with a lot of the peptides, of course, you could have, reactions to it as far as like allergic reactions, things like that, skin reaction. Some people do get a little bit of a rush of this peptide, like more kind of like a nauseated feeling.
Mhm.
Um, but other than that, for the most part, it's a pretty benign peptide where you don't get a lot of side effects with it.
Oh,
So
nice. Do you
yeah.
think it's going to replace all those sleep medications?
We'll
It
see.
should.
It
It
should,
should.
yeah.
So it
It should.
seems
It
like it
definitely.
should. Like
It's definitely
progesterone
something
and
that
DSIP, that's like we need a DSIP with progesterone combo and give it to
absolutely,
women, all the women who can't sleep.
100%,
Wow. Wow.
100%.
Um, it's like it's insane that it's like, when everything is changing, how so number three is your glow peptides, which I have bought it. I am
Yes.
still, I'm gonna be preparing it and trying to give it to myself first. But tell me more about the glow peptide. Why are they your favorite? Is the glow peptide more useful than the intravenous glutathione,
I mean, again,
or
I
it's like
think
they
that
work in conjunction?
they work. Yeah, everything. I mean, I think like things like glutathione are really important for certain things. They're more foundational. The glow peptide again has 3 separate peptides in it. But the first one, the GHK copper, what it does is on a cellular level, it actually upregulates the mitochondria to produce more collagen and elastin. And so, like, this is kind of like the foundation of how collagen is produced. A lot of times people will drink collagen, take it on their skin, all these types of things, but obviously it's not doing anything at the cellular level where GHK copper, besides for the fact that it is, important that copper kind of binds with the collagen itself, and that if you are deficient in copper, you're going to have problems producing like functional collagen. But besides for that, it actually does kind of upregulate the collagen production and the elastin production from the mitochondrial level. So that in itself, for women, obviously, you know, when we go through, perimenopause and menopause, obviously, one of the big things is they worry about their skin because of the fact that with the collagen being produced less, one of the reasons why it is produced less is because there's lack of estrogen, right? So that's a really important thing. So the glow peptide is one of those things that can actually work on a different pathway to help produce the collagen, produce the elastin to add as well as adjunct with the estrogen to help kind of give you that glow. The second peptide in it is BPC 157, which again, so important, so great, but even more than that. I mean, I talked about a lot of joint aches and injuries and stuff like that. BPC 157 is a peptide that lives in the gut. It lives in the stomach. And so one of the things that women have issues with is they have problems with their inflammation in their gut, leaky gut, which we could spend hours on talking about. But with BPC 157 specifically, it helps these issues, these gut issues, because that's really what it does. Like it's in the body in real life. It is a peptide that improves and helps to decrease inflammation in the gut and helps to decrease the overall kind of the problems that people have with gut health, and as well as absorption of everything that we're putting into our bodies as well, because of the fact that without gut health, what are you able to absorb? So these are the things that women have a lot of issues with. And BPC 157, besides for all its other things that I talked about, I think on the last one, as far as our joints, our aches and pains, it really has a huge component of its gut ability to decrease inflammation, which is so valuable. And the third one in there is TB 500, which increases angiogenesis, which is kind of like blood flow. So again, like just giving you more blood to the area, fine lines, wrinkles, scarring, all those types of things. You need the blood going to the area to be able to help kind of all these things. So glow peptide in itself, I think everybody should be taking it, honestly. Like
Is
every
that the glow peptide? Do you give it like anywhere in the body, or would you like suggest somebody put it in the areas of their face, facial structure where they need like a little more strength or whatever? Like if
I mean,
I do a therapy on someone, can I inject some peptides in certain parts of their faces where the skin
absolutely.
is more um, fine or needs a little strength?
Absolutely. I mean, you definitely can do that. I mean, I do it, for patients for hair replacement in the follicles itself, because the GHK copper is found to, because of the angiogenesis, because of, the reproduction of, the follicles improving, you can inject right into the follicles in the scalp like you would like a PRP or
Wow.
exosomes. And
Can it
so
be mixed with the PRP or no? Oh yeah.
So I mean, I haven't done that. PRP is a very kind of finicky product.
Right.
If with certain things, it really can. If it's very acidic, it can get deactivate some of the positive effects of PRP. So I haven't done it, but I would say like what might be a good protocol is to do like a PRP GHK like every 2 weeks, to kind of like give it a little time for your bodies to take it in at different times. So,
Oh, I get it. Yeah, no, that's great. So number three, CJC Ipamorelin. Now, what is that? Oh my
okay,
God,
so
these names. Who's making these names? Number one.
not I, Dr. Dan, but
We need to give them new names.
yes, I know.
What is CJC
So CHC
Ipamorelin?
and Ipamorelin, this is actually growth hormone analog, right? So a lot of people get very nervous when they hear growth hormone because of the fact that, yeah, if you're taking growth hormone in, exogenously and you're doing it the wrong way, it can have a lot of negative effects, including, if there are cancer cells, it can produce more. Now, what we're talking about here is we're talking about growth hormone analogs, the way that our bodies, we're not putting growth hormone in our system. What we're putting in our system is we're putting in something that helps our body kind of recognize, say, let's produce this. And our bodies produce the growth hormone normally. So the interesting thing about this peptide, CJC with ipamorelin, is that they work on two pathways the of producing growth hormone. There's one that's from the hypothalamus to the pituitary. The other one is called the ghrelin pathway. And so, like one of the interesting things about ghrelin pathway is that when we fast, so like ghrelin actually can make us hungry, but what we find is that when you fast, actually, it actually produces more growth hormone. So this is why I tell patients that when you're doing growth hormone analogs, you should do it on an empty stomach because you want your bodies to kind of produce this more. So with CJC, it actually works on the pituitary axis, and the ipamorelin works on the ghrelin pathway. And the reason why they're good is that sometimes if you're taking growth hormone analogs, it actually can make you hungry. Certain ones do. One that's called sermorelin will make you hungry. So for people who want to gain weight, muscle, it's good. That's a good one. But this one does not, because we don't want that to. For most of our patients, don't want to be hungry when they're taking it. So the ipamorelin actually blunts the hunger effect of the growth hormone analogs, and that's why it's great that they work together. But what does it do? So there was a study done, and there's only a few indications for growth hormone, and I kind of dove deeply in this for this podcast to kind of go through it with you. That like when people have like traumatic brain injuries or they have a tumor of the pituitary, they're going to be growth hormone deficient. So they looked at these patients and they said, like, what about these patients compared to like normal patients? What can we say about them? And what we could say about them is that for patients who are growth hormone deficient, they're going to have increased cardiovascular disease, increased risk of stroke, increased risk of Alzheimer's disease, increased risk of high cholesterol, increased risk of fat production, essentially decreased lean muscle. They have more fat, less muscle, increased risk of osteoporosis. So you put all these things together and you think about like what happens to our body as we get older. It's called just like like andropause, menopause. This is somatopause. So this is means that our growth hormone actually is being produced less as we get older. And so all these things that we're talking about are things that we as somebody who's getting older deals with because of the fact that our growth hormones are decreasing. And so if you do it in a responsible way and you do it in a way that your body is actually producing it itself, you're going to increase your overall lean muscle because of the fact that it's muscle protective, decrease the risk of osteoporosis, decrease the risk of high cholesterol, decrease the risk of cardiovascular disease. And not only that, the cognitive changes are dramatic for patients. There was a lot of studies done out in California. I think it was about a dozen years ago, and they found that patients who were going through Alzheimer's or or having issues with dementia, they were giving them growth hormone, and they were seeing dramatic positive effects with them. But again, they took it because of the fact that they were putting pure growth hormone in. They were having trouble kind of balancing and kind of managing it. So with the benefit of using growth hormone analogs is the fact that you're letting your body do it. So it's going to stop when it produces too much, feels like it's too much. And so you're not producing too much growth hormone. You're letting your body kind of produce it for you, but you're giving them the kind of like text message to kind of say, hey, how about we do a little bit of this? And you can see the body composition, memory, all the different types of things, obviously lean muscle, decrease in visceral fat, decrease in belly fat, all these things that, patients want are, there for the taking, just as long as you're doing these type of growth hormone, analogs responsibly.
Wow. I don't know. So we're like kind of, there is another layer of study that has to be done on this because
Yeah.
I am scared of growth hormone because sometimes I look at people and I feel that, their jaw lines have changed and they've turned into somebody else. Like I've seen some guys who are using, and I feel that it does it
So this so
change
this
their,
is so this
does it
so this
increase
is
their
different.
bone mass?
So this is different, Dr. Din. I agree that using growth hormone purely on its own is something that is something that you have to be cautious of. In this case, we're not. We're using growth hormone analogs, which
I
means that it pulses the growth hormone.
Yes.
It tells our body,
Yeah.
hey, listen, let's make this. It's not going to overproduce it because your body is still making it. It's going through the pathway of saying, just like how, just how we say we give HCG to patients and it helps them produce testosterone or progesterone for women. It's telling our bodies to do it. It's giving them kind of the kind of pathway, and our bodies will say, "Hey, enough, too much." I'm gonna have the feedback loop of not producing too much. Whereas if you just take growth hormone itself, yeah, you're taking it exogenously. If you take too much of it, your bodies are not going to be able to stop you because you're taking it. This is just giving your body the message to produce it. So it's very different from taking growth hormone itself. So the people who are taking it on their own, this is completely different, and that's why it has to be kind of put in a different classification.
Oh, wow. Okay. And what blood work would you check when somebody's on this?
So one of the major blood tests that you're going to do is something called IGF-1, which is kind of so like growth hormone itself has a very short half-life, so you really can't test it in the blood. It's like seconds. And what IGF-1 is kind of which is insulin growth factor 1, which is the peptide in the body that kind of does a lot of the heavy lifting, kind of helps with, the decrease in metabolic inflammation, increase in the muscle strength, decrease in the insensitivity. So all these things are going to be done by insulin growth factor because this is kind of the peptide that really kind of gives you, the kind of jumping point, because growth hormone itself has too short of a half-life to be actually do much. But you look at insulin growth factor, you'll see what the difference is. You'll be able to tell, like, is this too much or is too little? And obviously you all do all the other metabolic effects that you're going to be using in this case to see, is there inflammation, is there, how the hormones being affected. So, I mean, those are the major ones, but insulin growth factor is kind of like the major one to look at to track how your bodies are doing. Liver, kidney, obviously you always do that just to kind of look at how your body's responding to any of these types of things that you're doing in any case,
Yeah.
whether you're doing hormones or
Yeah.
or any type of medications.
And
But
are there any restrictions on someone who should not be doing this?
yeah, I mean, obviously, if a person has, active, cancer or any type of, significant risk of cancer, then, you don't want to, you want to consider, like not doing something like this. Anybody who, has, elevated, growth hormone for whatever reason, would be another patient that you'd kind of prevent it. But I mean, for the most part, there will be like short spike when you look at the data, there will be short spikes of where your blood pressure can be elevated a little bit, even your sugar can be elevated. But the ultimate effect of what the growth hormone does, over time, is it's actually going to lower the blood pressure. It's going to increase insulin sensitivity. It's going to decrease inflammation, and it's actually going to decrease your blood sugar, or your A1C in general. I mean, you know, for our bodies, it's really something that is incredibly important and valuable. And it's something that whether it's testosterone or hormone therapy, it's something else that we need to look at as like a medical field and say, like, this is also an issue, because of the fact that people get so scared of it, because of the people who have abused it, just like anything else. You have to look at it in a smarter way and kind of say, like, look at these people who lost the ability to have growth hormone and how their health was so like poorly, changed, completely. And it was the best way for us to kind of say, hey, these patients who can't produce growth hormone because they have a pituitary tumor or they had a traumatic brain injury, or they can't produce it anymore. How did their health, you know, change compared to an average patient. And it was dramatic that all the things that I listed off earlier were present, like that they had increased cardiovascular risk, increase, risk of cognitive decline, increased risk of high blood pressure, low cholesterol. So all these things are there and they were present. And, you know, it really is something that people need to kind of like look at it in a different way.
I one other question. It seems to me like all these peptides, it's like you're explaining an entourage of just the GLP-1s, that they should be all be like in some doses given to everyone.
Well,
Um,
like somebody asked me, so like, if you had to pick one peptide to take, you want to ask that question, Dr. Jen? Why don't you
yes,
ask me that? Go ahead, ask me that
yes,
question.
it is on my
On your list?
questions at the end. It's on my list of fast questions. But yes, if there was like just one that I had to take, which one would it be?
Okay.
GLP-1, I
So
guess.
I love you asked this question because my answer is, let's say you went into a store to get tires, right? And they said, I just want one tire to drive my car. Not going to work. So that's the thing is
Got it.
your body has a lot of different pathways, different things that are going on. And so what these peptides are doing is are creating like a symphony within your body. You need each piece to be able to come together. And they all do things that, have similar positive effects. We know that our body, and not only that, like diet, exercise, these things are they have to be part of a healthy lifestyle. So
Yeah.
these things are like foundational as well, that you can't just say, well, I'm going to take these peptides and I'll be healthy. No, you have to diet, you have to eat the right things, you have to exercise. So it's not a one-off thing. You need everything together to like create a better life for yourself and create a
Yeah, you
healthier
need a
life.
full car. I don't need just one tire.
That's right, exactly.
I need my vessel to be working.
That's right. That's right.
Let's go on to the last peptide on your list. And it looks like your list is growing, but like, because just the Glow has three.
Yes.
So it's not five because Glow has three components.
Sure, sure.
And CJC has like also another
Sure.
component.
Yes.
So the
Yes.
last one on your list is PT141. What
Yes.
is
So,
that?
so this is a very cool peptide, and I actually did a little post on this morning. So look at the Modern Man and Vital Wellness Club to look at my post. It was a Valentine's Day. So
Right.
PT141 is an interesting peptide. It's actually FDA approved for women who are perimenopausal and postmenopausal for something called essentially hypoactive sexual desire disorder. And
Oh,
so, long name, but what it means is that for a lot of women who become peri and postmenopausal, what happens is that they go into decreased, desire, decreased satisfaction, decreased lubrication, for intimacy. What they found is they did a study with this peptide, and what they found is that it works in two pathways. The first thing it does is it works in the brain and some part of the brain called the melanocortin. And what that does is that increases the intimacy by increasing desire, libido, as well as overall kind of closeness and satisfaction. They found. So when they did the study, they realized that patients who received the PT141 versus placebo increased all these factors, including vaginal lubrication, by almost 2.5 to 3 times. And so in 2019, the FDA approved this for that reason, essentially for women to have better better satisfaction, better libido, as well as better desire. And it's mostly a psychological effect. But the other thing that it does is it increases nitrous oxide. And what nitrous oxide does is it dilates the vessels. And so that increases blood flow to the vaginal area. But as well, for men, interestingly enough, this actually, at a different dose, it's not the same dose as women, but this actually treats ED for
Oh, really?
men. Yes, but
Wow.
even better than that, because it affects the brain, it actually increases. So most of what the big problem with Viagra, Cialis, all those things is they increase the vessels. So the men, do get relief from ED, but they don't have the psychological effect. They don't have the desire, the satisfaction, the libido changes with Viagra.
Yeah.
But this has the added benefit because it increases the nitrous oxide, so it does dilate the vessels, increase blood flow, to help, erection and kind of, and help ED, but also it gives them the psychological effect of increasing their desire, increasing their satisfaction, increasing their libido overall, with this. So for men and women, and I said this is a better Valentine's Day gift than chocolate and candy. Um,
Oh my God.
that this peptide is my Valentine's gift to all my patients. But
That
yes,
that is like both my, so it's like kind of a bonding, it's like a bonding peptide.
yes, it's definitely a bonding peptide. I mean, we can go into next time oxytocin, which is the bonding peptide, but
Yes.
but
Oh,
we'll get.
is oxytocin? I didn't see that on the list.
I
Yes.
didn't put it on the list. I mean, oxytocin is it's a long discussion. We might need
Yeah,
an
we need
entire podcast on
a
that
thing.
because
Yeah, that is your next cycle over here. So we're gonna add the oxytocin. So how often do we need PT-141? Is this an injectable
so
or an oral?
so this is again. So you can do there is like nasal compound, but also injectables. It's for women 30 minutes to an hour prior to activity. For men, we say 45 minutes usually is enough time prior to activity for it to work. So 45 minutes to an hour maybe, but for women, again, it's like 30 minutes to an hour. And so the interesting thing about it is that it works for women as well in the way that it does increase lubrication because it is creating more blood flow to the area. Because of the fact that with nitrous oxide, what it does
Yeah.
is it causes vasodilation, and similar to how PDEs work with Viagra, Cialis, all those things, but those work on more of kind of a direct pathway where this is gives you that, but also gives you the kind of the psychological effect because it affects the melanocortin in the brain and it helps
Yeah.
to help the desire and,
Yeah.
and libido. So
So in your list of five, the ones that are currently FDA approved is this one, PT-141, and then the GLP ones.
yes,
Uh,
correct.
where are they on that trajectory of getting approval? These compounded some of these peptides.
So,
What do you
so
see?
like, so CJC Ipamorelin has been in studies. Now, the one thing about it is that it does cause, like, I mean, if you've ever taken niacin B3, you can
Flushing.
get flush, right?
Yeah.
And so you can with certain patients, they can get, a flush, maybe a significant flush. They were right in this middle of the study, like how tesamorelin. So tesamorelin, I talked to you about, right?
Yeah.
Is another analog. So it was tracking with tesamorelin, but the problem was that people were leaving the study because of the flush, and so this is the reason why that CJC ipamorelin kind of like had not got to that point yet because they had issues with people, staying in the study with the flush. Now, what I tell patients is that, a lot of times we'll do growth hormone analogs in the evening because that's when you want the surge of growth hormone. But you can do it in the morning as well, and because of the fact that CJC is different because it has a longer pulse, for growth hormone. So you can do it in the morning. There's less chance that you'll get flushed. You'll be fine, and you'll be able to take it. and get the effects of it with dealing with, the flush where it's not as dramatic as, in the evening. So that's really the major thing with CJC. There are studies with most of the studies with GHK. There's dermatological studies that are being done, and again, why do a lot of these things not get tested very well? Because who's benefiting from it? Well, the GLPs, we knew who was benefiting from them and why the studies got done, and they're great, and thank God that they did. But again, for a lot of these other things, it's a matter of if the companies that put the most money in research think that they're going to have a financial benefit. That's a lot of times how things are kind of run by. But the PT-141, really interesting peptide, and I think for a lot of women and men, it's something that's incredibly valuable to them. So I love this peptide too. So
Yeah. And
yeah.
DSIP, when is that going to get FDA approved?
Well, maybe we'll do the studies together, Sophia.
I'll enroll
I
myself right
do
away.
have a lot of patients on it, actually, and they're getting great results with it. So, I
So
mean,
yeah,
so it's, the hard thing with doing research is you have to have the ability to, there's a lot of regulations with it. So you have to have the placebos, you have to have, the dosing and everything like that. So it's difficult, but I do think that, just like anything else, like when they see benefit of it, and then that's a lot of time when enough people kind of get on it and see benefit on it. This is how things get moved forward. I always say, like, is the best. Niacin is the best example of something that's natural that somehow the drug companies got their hands on because they realized it works for to lower triglycerides, and so they just took this vitamin B3, and they're like, okay, now it's a drug. It's niacinamide. And because of the fact that it works, it's obviously works. So like when things work, sometimes, life finds a way. So we hope.
yeah, yeah. So no, we will see it, and this is how progress also takes place. Somebody starts using it, and then they
Sure.
come out, and then it
Conversation.
benefits everyone. And these conversations do need to take place,
Right.
and we have to examine what works and what doesn't.
Right.
Um, I think that we kind of covered pretty much most of the things that were on the schedule. We went a little over it, but I am glad that we were able to capture as much of your, brain as we could in one episode. And I will need to have you again, and I'm going to get myself on your schedule.
Yes.
Um, and let's work on the evolution of medicine. Sometimes medicine evolves slowly and sometimes very enthusiastically. And I feel that peptides is where we are very enthusiastic about it. And some of them have worked wonders. For example, the GLP-1s is going to be change the shape of longevity and how we experience menopause. Hormones and peptides sit at that delicate edge between fear and fascination. And the question isn't whether we should use them. The real question is, can we apply them with precision, humility, and respect for biology? Because longevity is not about chasing youth, it's about extending vitality responsibly. Dr. Frankel, thank you so much for helping us navigate this with clarity rather than hype. And to our listeners, stay curious, stay skeptical, and stay informed. This is Bathroom Diaries. If you need, please follow Dr. Frankel. He has a podcast called The Modern Man, where you will find a lot more of this. Dr. Frankel, is there any other handle,
Yeah,
social
we
media that you would
actually
like to tell us?
Yeah, we actually have a new Instagram and website, Vitali, Wellness Club, Vitale, Wellness Club. You can find us on Instagram. You can find us on Facebook, and as well as www.vitalewellnessclub.com is our handle. So, and of course, Modern Man, I'm always there, always chatting and talking about things on there. So I just usually like pick up my phone, throw the camera in front of me and start yapping. So you could listen to my ravings, at any time of the night.
That's awesome. Dr. Frankel, you should be also on TikTok because one of the clips that I published on TikTok for about peptides, the first episode, it
Mhm.
almost has like over 50,000 views. So
Yes,
I'd
yes, we
I'd
will, we
link
will.
it up with your Vitali Wellness as soon as you are on there.
Perfect.
Well, thank you so much. And I am going to stop recording.